Traumatic optic neuropathy. Traumatic optic neuropathy is of two types: direct and indirect. Direct is less common and involves direct anatomical disruption of optic nerve in cranio-orbital trauma. Indirect is enclosed injury due to shearing or avulsion of nutrient vessels. Characteristic features of traumatic optic neuropathy are loss of vision, dilation of pupil light reflex. There occurs loss of direct light reflex on affected side with preservation of ipsilateral consensual light reflex and loss of consensual light reflex on contralateral side with preservation of contralateral direct light reflex. Related to afferent RAPD, Marcus skin pupil is first sign. Preservation of near reflex as an optic nerve is not involved in the pathway of near reflex. Light brightness sensitivity and contrast sensitivity are diminished. Subject to red color saturation, light intensity are of two best two best for overall optic nerve function. Visual field testing is in an awake and fully cooperative patient can be more revealing than visual acuity determination. Visual field testing is done perimetry. Visual fields show central or centroscleral chromatoma. Visual evoked potential shows reduced amplitude. Imaging high resolution CT scan is the diagnostic procedure of choice for determining the site of trauma. MRI is the investigation of choice for visualization of optic nerve. Treatment is mostly steroids. Papilloedema is the it terms like disc edema and look like and per se mean swelling of optic disc. Over papilloedema has been reserved for passive disc swelling associated with increased intracranial pressure, which is almost always bilateral, although it may be asymmetrical. The term disc edema or disc swelling includes all causes of active or passive edematous swelling of optic disc other than cause of papilloedema. Cause of disc edema: inflammation such as papillitis, neuroretinitis, papillophlebitis, uveitis, ocular hypotony due to any cause, vascular cause, ERVO, diabetic valvulopathy, uremia, etc. Orbital cause are tumors, Graves, orbitopathy, orbital cellulitis. Inflammatory conditions include leukemia and lymphoma. Idiopathogenesis causes as described above. Papilloedema is a non-inflammatory edema of optic disc which occurs secondary to raised intracranial pressure associated with following conditions. Congenital conditions include aqueductal stenosis and craniosynostosis, intracranial space occupying lesion, ICSOL. These include brain tumor, abscess, tuberculoma, gamma, subdural hematoma, aneurysm. The ICSOLs in any position excepting middle oblongata may induce papilloedema. It is most frequent associated with tumors arising in posterior fossa which obstruct aqueduct of sylvius and leads to pituitary tumors. Thus, the ICSOLs of cerebellum, midbrain, and parieto-occipital region produce papilloedema more rapidly than mass lesions of other areas. Further, the fast-progressing lesions produce papilloedema more frequently and acutely than slow-growing lesions. Intracranial infections such as meningitis, encephalitis may be associated with papilloedema. Intracranial hemorrhages, cerebral as well as subarachnoid hemorrhage can give rise to papilloedema, which is frequent and considerable in extent. Idiopathic intracranial hypertension, also known as pseudotumor cerebri, is an important cause of raised intracranial pressure. It is poorly understood condition, usually found in young obese women. It's characterized by chronic headache, bilateral papilloedema without any ICSOLs or enlargement of ventricles due to hydrocephalus. Systemic conditions include malignant hypertension, pregnancy-induced hypertension, cardiopulmonary insufficiency, blood crisis, nephritis. Diffuse cerebral edema from blunt head trauma may cause papilloedema. Cerebral venous sinus thrombus may also cause papilloedema. Unilateral versus bilateral papilloedema. Disc swelling due to ocular and orbital lesion is usually unilateral. In majority of the cases with raised intracranial pressure, papilloedema is bilateral. Our unilateral case as well as unequal change do occur with raised intracranial pressure. A few such conditions are as follows: Foster Kennedy syndrome. It is associated with olfactory or sphenoidal meningioma, frontal lobe tumors, In this condition, there occurs pressure optic atrophy on side of lesion and papilledema on the other side. Pseudo-Foster condition is characterized by occurrence of unilateral papilledema with raised intracranial pressure, pre-existing optic atrophy due to any cause. On the other side, pathogen till date, high-risk theory is the most accepted one. It states that papilledema develops as a result of stress of exoplasm in the pre-laminar region of optic disc due to an alteration in the pressure gradient across the lamina corposa. Increased intracranial pressure, malignant hypertension, orbital lesion produce disturbance in the pressure gradient by increasing the tissue pressure within the retrolaminar region, while ocular hypertony alters it by lowering the tissue pressure within the prelaminar area. Thus, the axonal swelling due to exoplasmic stasis is prelaminar region in the initial structural alteration, which in turn produce venous congestion and ultimately extracellular edema. This theory discusses the old view that papilledema is due to compression of central retinal vein by raised cerebrospinal fluid pressure around the optic nerve. Evolution occurs, papilledema usually develops quickly, appearing within 1 to 5 days of raised intracranial pressure. In case with acute subarachnoid hemorrhage, it may be developed even more rapidly. However, recovery from fully developed papilledema is rather slow. Clinical feature, general feature, raised intraocular pressure, headache, nausea, and projectile vomiting and diplopia may be seen. Ocular features, amaurosis, visual acuity, pupillary reaction usually remain fairly normal until the late stages of disease when optic atrophy sets in. So, loss of vision is not a common feature of papilledema. Clinical feature of papilledema can be described under 4 stages: early, fully developed, chronic, and atrophic. Okay, early papilledema are usually symptoms are usually absent, visual acuity is normal, papillary reactions are normal. Ophthalmic features of early papilledema are obscuration of disc margins are involved first, followed by superior, inferior, and temporal, blurring of peripapillary nerve fiber layer, absence of spontaneous venous pulsation of disc, mild hyperemia of the disc, splinter hemorrhage in the papillary region. Visual fields are fairly normal. Established patient may give history of transient visual obstruction in 1 or both lasting a few seconds. After studying, visual acuity is usually normal. Pupillary reaction remain fairly normal. Ophthalmoscopic features. Apparent optic disc edema is seen as its forward elevation above the plane of retina, usually up to 1 to 2 mm. Physiological cup of optic disc obliterated. Disc becomes markedly hyperemic and blurring of the margin is present around multiple cardinal spots and superficial hemorrhage may be seen on the disc. Veins become tortuous and engorged. In advanced cases, the disc appears to be enlarged and elevated, mushroom or dome shaped, so that the vessels bend sharply over its margin. There occurs difference of 2 to 60 between vessels at the top of the dome and those of the retina by internet ophthalmoscope. Definitive parallax can be elicited. Patterns line, that is circumferential grayish white folds, may develop due to separation of nerve fibers by edema. Rarely, hard X-rays may radiate from fovea in the form of incomplete star, macular star, or macular fin. Visual fields show enlargement of blind spot. Chronic or long-standing vintage papilledema. Symptoms: visual acuity is variably reduced depending on the duration of papilledema. Pupillary reaction are normal. Ophthalmoscopic features is acute hemorrhages and cardinal spots resolved when papillary edema is resolved. The optic changes give the appearance of dome of a champagne cork. Small drusen-like crystalline deposits, corpora malacia, may appear on the disc surface. Visual fields, blind spot is enlarged and visual fields begin to constrict. Atrophic papilloedema. Atrophic papilloedema develops after 6 to 9 months of chronic papilloedema and is characterized by severely impaired visual acuity. Pupillary reaction, light reflex is impaired. Ophthalmoscopic features of the so-called post-neuritic optic atrophy are as below. There occurs grayish-white discoloration color of the disc due to atrophy of neurons and associated gliosis. Prominence of disc decrease in spite of persistent raised IOP. Retinal arteries are narrowed and veins become less congested. Whitish sheathing develops across the vessels. Visual fields, concentric contraction of peripheral fields become apparent as atrophy sets in. Differential diagnosis. Papilledema should be differentiated from pseudopapilledema, papillitis. Pseudopapilledema is a non-specific term used to describe elevation of disc similar to papilledema in conditions such as optic disc diffusion, hypermetropia, and precision highlight tissue. Papillitis and pseudopapilledema due to hypermetropia as enumerated. Treatment and papilledema in neurological emergency requires immediate hospitalization. Urgent neuroimaging, MRI with gadolinium enhancement. is required. Optic atrophy. Optic atrophy refers to degeneration of optic nerve, which occurs as an end result of pathological process that damage axons and anterior visual system, that is from retinal ganglion cells to lateral genital body classification. Primary versus secondary optic atrophy. Primary to simple degeneration of nerve fibers without any complicating process within the eye. Syphilitic optic atrophy of tabes dorsalis. Secondary occurs following any pathological process which produces optic nerves and papilledema. Recently, most of the authors have discovered the use of time-honored but non-informative classification. Fundus photographs showing papilledema, early established chronic and atrophic. Early established chronic and atrophic. Ophthalmoscopic classification. Primary, consecutive glaucoma minus posterior vascular. Ascending versus descending optic atrophy. Ascending follows damage to ganglion cells or nerve fiber due to disease of retina or optic disc. In it, the nerve fiber degenerates and progresses from eyeball towards the genital body, descending from the region of optic tract, chiasma or posterior portion of optic nerve towards the optic disc. Damage occurs beyond lateral genital needles. Optic radiation occipital cortex does not cause optic atrophy. Pathology feature degeneration of optic nerve fibers associated with attempted but unsuccessful degeneration, which is characterized by proliferation of astrocytes and glial cells. Ophthalmoscopic appearance of atrophic optic disc depends upon degree of loss of nerve fibers vis-a-vis gliosis. Degeneration of nerve fibers may associate with excessive gliosis. These changes are pathological features of consecutive postneurotic optic atrophy. Degenerative gliosis may be orderly and proliferating astrocytes arrange themselves in longitudinal columns. Such pathological features are seen in primary optic atrophy. These are the differentiating features between papilledema, papillitis and pseudopapillitis. Bilateral, unilateral or bilateral transient attacks are blood vision, marked loss of vision of sudden onset, defective vision, absent pain, present with pain present and pain absent. Fundus examination. Media clear, posterior vitreous haze is common, clear, media is clear, discoloration, red and juicy appearance, marked hyperemia, reddish, disc margin blurred, not well defined, 2 to 6 diopters, disc swelling, usually not more than 3 diopters, depending upon the degree of hypermetropy. Peripapillary edema present, absent. Venous engorgement more marked, less marked, not present. Retinal hemorrhage is marked, usually not present. Retinal exudate more marked, less marked, absent. Macular star may be present, macular fan may be present, absent. Feels enlarged blind spot, scleroscotoma, no defect. Vertical over pool of dye due to leakage, minimal leakage of dye, no leakage of dye. Etiology: primary optic atrophy, consecutive optic atrophy, postneurotic, glaucoma and vascular. Then etiology, then clinical features of optic atrophy. Primary, it results from lesions proximal to optic disc without antecedent papilledema. Its common cause of multiple sclerosis, retrobulbar neuritis, Leber's and other hereditary optic atrophy, intracranial tumors pressing directly on the anterior visual pathway, and avulsion of optic nerve, etc. Consecutive optic atrophy, it occurs following dissection of ganglions and secondary to degenerative or inflammatory lesions of choroid or retina. Its common cause of diffuse choroidal retinitis pigmentosa dystrophy, such as retinitis pigmentosa and pathological myopia. Most neurotic, it is secondary optic atrophy is develops as equal to long-standing papilledema. Glaucoma optic atrophy, it results from effect long-standing intraocular pressure. Vascular optic atrophy, it results from a condition producing disc ischemia. These include giant cell arteries, severe hemorrhage, severe anemia, quinine poisoning. Clinical features of optic atrophy: loss of vision is sudden or gradual onset. People is semi-direct electrifies, very shaggies are absent. Swinging flashlight test RAPD visual loss will vary with distribution of fibers that have been damaged. In general, the field loss is peripheral in systemic infusion, central in focal optic nerves, and eccentric when nerve or nerve tracts are compressed. Ophthalmoscopic appearance of disc will vary with type of optic atrophy. However, ophthalmoscopic features of optic atrophy is general or pallor of disc, decrease in number of small blood vessels, Castenbaum index. Primary optic atrophy. Color of the disc is chalky white or white with bluish hue. Its edges are sharply outlined. A slight recession of the entire optic disc occurs in total atrophy. Lamina corpus is clearly seen at the bottom of the physiological cup. Consecutive optic atrophy, disc appears yellow waxy. Its edges are not so sharply defined as in primary optic atrophy. Retinal vessels are attenuated. Post-neuritic optic atrophy, optic disc looks dirty white in color due to gliosis, and its edges are blurred, and physiological cup is obliterated and lamina corpus is not visible. Retinal vessels are attenuated and perivascular sheathing is often present. Glaucomatous optic atrophy characterized by deep and white cupping of the optic disc and nasal septa of blood vessels. Ischemic which is a pallor of the optic disc associated with marked attenuation of vessels. Primary, secondary, consecutive, post-neuritic and ischemic optic atrophy. Differential diagnosis: primary versus secondary and consecutive optic atrophy. Optic given 13.3, we will see appearance chalky white, dirty grey, waxy color, well defined, lamina corpus well seen, obscure well seen, vessels normal, peripupillary sheathing, attenuation, surrounding retina healthy, hyaline bodies, Dusan pathological lesion. Non-pathologic pallor of optic is seen. Axial myopia, infants, elderly people with sclerotic changes. Temporal pallor is associated with a larger physiological myopia. Pathologic cause of pallor disc. Treatment of underlying cause may help in preserving some vision in patients with partial optic atrophy. Symptomatic disturbance of vision: night blindness, neutropia. Occur in patient. Rod dysfunction also in patient having media opposite advancing POAG. Rod dysfunction, night vision in a function of rods, therefore condition in which function of this nerve endings is damaged will result in night blindness. Vitamin A deficiency, congenital high myopia, familial congenital Oguchi disease, media opposites. Night blindness also developing condition of ocular media interfering with light rays in dim light. Paracentral lenticular and corneal opposites, advanced POG, day blindness, hamarlopia. It is disturbance of vision in which the patient is able to see better in dim light as compared to bright light. Congenital aphasia, central lenticular opposites, polar cataracts, central corneal opposite, color blindness. Color blindness. An individual with normal color vision is known as trichomate. This is because the normal human eye can appreciate three primary colors: red, green, blue, due to presence of three different colors: red sensitive, green sensitive, blue sensitive. All colors of spectrum can be perceived by fusion of three colors. Young-Helmholtz theory. Congenital color blindness, hereditary condition, 3% male, 4.4% females. Dyschromatopsia, achromatopsia. Dyschromatopsia, it literally means color confusion due to deficiency of mechanism to perceive colors. It can be classified into anomalous dichromacy, blue cone monochromaticity, anomalous trichromatic color vision. Here the mechanism to appreciate all the three primary colors is present but is defective for one or two of them. Protoanomalous, deuteranomalous, it refers to defective red color appreciation. Deuteranomalous refers to green color appreciation. Ishihara pseudo isochromatic chart to check the color vision. Tritanomalous implies defective blue color appreciation. Dichromatic color vision: protanopia, deuteranopia, tritanopia. Protanopia red color, deuteranopia green color, tritanopia blue color. Red color deficiency is more common. Such a defect is a source of danger in certain occupations such as drivers, sailors, traffic police, etc. Blue cone monochromatism is a condition of complete absence of red and green color cone function. Poor day vision but normal night vision. Color vision severely limited. Only difference in blue hues, reduced visual acuity, small amplitude nesting mass, photosensitivity. Achromatopsia, it is an extremely rare condition. Rod monochromatism, total color blindness, deep blindness, nystagmus, fundus is normal. Acquired color blindness, blue yellow impairment, red green deficiency, acquired blue color defect. Blue yellow impairment seen in retinal lesions such as CSR, macular edema, shallow retinal detachment. Red green deficiency seen in optic nerve lesions. This is optic neuritis, Leber optic atrophy, compression of optic nerve. Acquired blue color defect may be occurred in old age due to increased sclerosis of crystalline line. It is owing to physical absorption of blue rays by increased amber color pigmented nucleus. Test for collision, the screening: Ishihara, protons, deuteron color, qualitative classification color brains proton, neutron, triton. Quantitative degree mild, moderate, marked. Pseudochromatic Ishihara chart, Edridge Green Lantern test, Farnsworth Munsell 100 hue test, Farnsworth D15 hue discrimination test, City University color vision test, Nagel anomaloscope, home screen wool test, amaurosis is complete loss of sight in one or both eye in the absence of ophthalmoscope or other marked objective sign. Amaurosis fugax. It refers to sudden temporary painless monocular vision loss occurring due to transient failure of retinal circulation. Common cause carotid transient ischemic attack, embolization of retina. Embolization of retinal circulation, papilledema, giant cell arteries, retina, dizzy, migraine is the broad abnormal symptom of central retinal artery, carotid artery occlusion. Clinical characteristics: an attack of amaurosis fugax is typically described patient as curtain that descends from above or ascends from below to occupy the upper or lower halves of the visual fields. The attack lasts for 2 to 5 months and resolves in reverse pattern for progression, leaving no residual deficit. Due to brief duration of attack, it is rarely possible to observe fundus. When observed shortly after an attack, the fundus may either normal or reveal signs of retinal ischemia such as retinal edema, small superficial hemorrhages, in some cases retinal emboli in form of white plaques, fibrin platelet aggregates. Uremic amaurosis, it is sudden bilateral complete loss of sight occurring probably due to effect of certain toxic material upon the cells of the visual center in patients suffering the acute nephritis, eclampsia of pregnancy, renal failure. The visual loss is associated with dilated pupil, which generally react to light. Fundi are usually normal except for coincidental finding of hypertensive retinopathy. When usually vision requires in 12 to 48 hours. We will see in the fourth part of the video. Thank you.